Welcome back to another episode of Now I Know. I'm Sam Barry.
And I am Sud Koushik. Excited to be back.
Looking really tan, Sud, and relaxed. Hopefully you had a great honeymoon. It looked amazing. Can you tell the viewers a little bit about where you went and just how amazing it was?
I am incredibly lucky. My wife and I did a honeymoon. We went to Singapore. We spent 5 days in Singapore, and then from Singapore we went to Bali, which is just amazing. Probably our favorite aspect of the trip. And then after Bali, we did go to the Maldives and spent close to a week in the Maldives as well. So I did get a lot of sun. You're right. And probably should have worn sunglasses more because that UV exposure was pretty intense.
Yeah, well, you've got the built-in UV protection, right? You've got Evo helping you out.
I got Evo helping me out, and I'm hoping for the best.
Yeah, only the corneas are being affected by that. So as long as you don't have any UV keratitis, you'll be all right.
Yeah, I just also don't want any pterygium down the road. Then I'll have to see you.
That's fair. Nobody wants to see me, so that's a fair point. Yeah.
Oh man, I walked into that. I set that up.
You set me up for that. That was good. Yeah, but pterygium surgery, we got to cover that sometime. That's a good topic.
Yeah, that'd be a great topic. Yeah. There's a lot of little nuances with it, so I think it'd be good.
Yeah, some good nuances, and probably we should have a guest for that one. I feel like because people that treat them all the time, like Australia or Central America, they probably have some tips and tricks even for us. You know.
Yeah, no, that'd be
what's
great.
Today's topic? What are we covering?
Before we jump into it, I gotta say there was big news on your end too that I heard, and it made me a little jealous because now I know that you're totally off the market. Is that right?
That's right. Tori and I got engaged. Well, I proposed, and luckily she said yes. So very, very lucky. Yeah,
that is awesome.
And I like how you worked the podcast name into that. You said, "Now I know that you're off the market." That was smart. That was good. Good plug there. But yeah, we're really excited. Yeah.
That is fantastic. And then you did a marathon literally the day after. That's freaking amazing.
Yeah, shout out to Claire and Jared, my brother-in-law and sister. They were there, and I surprised Tori, but they were there taking photos. So we got some good photos and got it on tape and everything. So it was super cool. Amazing. It was at Cannon Beach in Portland, which is just a beautiful setting. So when you proposed to Jen, were you on the West Coast? Where were you? I know you were on the beach somewhere.
We were on the beach. Yeah, we were in Hawaii.
Hawaii, okay.
Done a trip there, and so the timing was great. I was like, let's do it here.
Yeah. So same ocean, Pacific Ocean, but
the same ocean,
a couple thousand miles away. Yeah.
Yeah, exactly.
Well, exciting news all around, man. Yeah. I think we can just end the episode there. That was perfect.
I think we're done. I think we took a long hiatus, and then we congratulated each other on these big milestones, and then we just wrap it up.
Yep. That's what the listeners want. I mean, that's really what they came for. Yeah.
That's right. Well, no, let's jump in. I mean, like you said, the topic for today will be about fellowship and fellowship experiences. Both you and I did a fellowship after completing our residency, and we'll definitely share that information with the listeners. But I think before we go into that, we were just going to chat a little bit about just the educational process to become an ophthalmologist. And I'll kind of outline a little bit, and Sam will jump in here. But basically, you do 4 years of undergrad, and then you apply to medical school, and then you complete medical school, which takes another 4 years. And during medical school, your third and fourth year, you are getting ready and applying for ophthalmology residency. And then after accepted, you complete 4 years of residency, one of which is kind of an internal medicine or surgical preliminary year, but has now since changed and kind of become more integrated into the ophthalmology curriculum. So that's a big benefit for our newer ophthalmology residents joining the field, not having to slug it out for a whole year doing internal medicine or general surgery, which makes me a little bit jealous. I don't know about you, Sam.
Same here. Pros and cons, though. There's pros and cons for anything like that. I mean, I loved my intern year. Got to live in Chicago for a year, and then have 3 years of residency at Mizzou. So seeing a city for a year is cool. But professionally and in terms of development, it's probably for the best to be in the same place for all 4 years, make those connections, and have a few months in your department doing that. So I agree with you. Overall, jealous. But still happy with the experience we had.
Yeah. Definitely. Yeah. And then basically after you complete your ophthalmology residency of 4 years, you can go out and you can start practicing. And fellowship is a completely optional experience. So not all ophthalmology graduates go on to complete fellowship. But those that do actually have a wide variety of subspecialties to choose from. And we can talk about kind of the brief offerings that are there, but Sam and I obviously chose a very specific path, which I think both of us can agree we're very happy with. But I know we have great colleagues who chose other paths. Going through that, I mean, if you're enjoying retina, there is a retina vitreoretinal fellowship for you. If you enjoy glaucoma becomes a fellowship option.
Can anyone enjoy glaucoma? Sorry to interrupt you, but gosh.
Thank
goodness for Dr. Max Court and Ike Ahmed, and just fantastic people with huge hearts. And treating glaucoma is difficult when it gets to that end stage glaucoma, which is what they do day in and day out. That's tough. Anyway,
it's tough, and they do great work. And I'm glad they're doing that, so we don't have to.
Yeah. So you did retina glaucoma, but oculoplastics, neuro-ophthalmology, and pediatrics, and then of course cornea. And I think refractive, kind of in with cornea, but also totally by itself, refractive and refractive cataract fellowships.
Yeah. I think to all the listeners, just going to say, I mean, for such a small piece of anatomy, there is a lot of different subspecialties that you can get into, and there's just a wealth of knowledge. So I think it's just a great field, no matter what you pick. And I think the best part too with the fellowships are, even if you pick a certain subspecialty, you're still completely within your right to practice kind of a comprehensive ophthalmology. So I think that's a great option for anybody to still always kind of lean back on the basics and the fundamentals.
Yeah. So just to recap for the listeners, so we had, after high school, we have 4 years of undergrad, 4 years of med school, 4 years of residency. So we're up to 12 years. So take high school, everything up to high school, and you do that again, another 12 years, right? And then after that, you can decide whether or not to do fellowship. And that can be a year, like you and I did, or it can be 2 years for some fellowships. Mostly the retina fellowships and oculoplastic are 2 years. But there's a handful of other fellowships that are 2 years as well.
Yeah, and Sam, some people actually complete multiple fellowships too, right? So
that blows my mind.
Blows my mind. But we do have those people out there, and they are crushing it. They end up doing maybe cornea plus glaucoma, or they do some other combination that I
guess those ocular oncology folks will do usually 2 years of surgical retina, and then an ocular oncology. Usually, not always, but that's another 3 years on top of basically your 3 to 4 years of residency. So doing all that again. I mean, that's just a lot of training.
And definitely for any listeners in the general public, it hopefully gives you some level of confidence that the surgeons that are out there have really undergone a lot of training, a lot of education before they're out there helping improve your vision.
All those things are just tough hurdles, and we gotta celebrate along the way. So you finished fellowship, which is awesome. So you gotta celebrate that. Finished. I mean, training at this point. Training is done, unless you decide to go back and do another fellowship, which don't do it.
Don't do it.
You're good.
You're good. I'm good. I like where I'm at. Yeah.
So that's awesome.
Yeah, you're right.
That's awesome.
You got to celebrate those successes.
Can you tell us about your fellowship and what it was like and how you decided to do one? So for like our medical school and resident level people out there that are listening, just pros and cons, kind of how you went through the decision-making process when you made the decision, how you ended up at the practice you're at, and then we'll get a little bit later into, what benefits you saw and what you, feel like you accomplished now that you're done with the year.
Yeah. So I think the decision to pursue a fellowship during residency is actually very similar, at least in my experience, to the decision to actually choose your residency when you're a medical student. You're kind of searching out for what you enjoy the most, and maybe also searching for what you dislike, just so that you can exclude things very easily. Probably also looking at the type of people you're surrounded with and kind of seeing if you mesh into that environment, and that's the day-to-day seems very appealing to you. So during my residency, I probably would say in my PGY3 year, so essentially mid of my residency program is when I really started thinking, do I want to pursue a fellowship or do I not? And then from there, understanding that I really enjoyed cataract surgery, which is kind of the bread and butter of your ophthalmology experience as a resident. I never wanted to lose that or give that up. I just wanted to continue getting better at that, improving at that. And with that, started exploring things like refractive surgery and cornea-based surgery. So that's what led me down the path of picking something in the anterior segment. I think when you're actually deciding and you've narrowed down to something like cornea refractive, you still have to make that decision whether doing a fellowship is really going to improve for the long term your skills in that field, or do you feel like you'd still be able to get to the same place if you didn't do the fellowship and kind of develop those skills on your own? You can still always go and do wet labs or mentorship programs. You can reach out to colleagues that have completed fellowships in that field and kind of work with them and get mentorship from them. So there's no one size fits all or straight path. It's just a kind of decision you have to make. And for me personally, I think it was the fellowship gives you that structure, and it gives you also a very well-defined number of experiences you're going to have within a certain procedure, surgery. And so, in that defined period of time of, let's say, 1 year, I'm going to do X amount of this procedure and X amount of this procedure. And so when you're finishing, you have a pretty strong confidence level in those procedures. And I think you can get that even without the fellowship, but I think it's going to take you a longer time to get those numbers and also maybe a longer time to feel as confident or familiar with those procedures. So I think when you make that distinction, for me, it was very easy to say, hey, I just want to do a fellowship. I want that controlled environment. I want people I can bounce ideas off of and learn from, and have that experience all done kind of within 1 year, so that I can just get out there and start doing that for my patients, feeling very confident.
I couldn't say it any better. I mean, that was perfect. And it's so funny because we briefly kind of discussed what we talk about today, but I've had that exact same thought multiple times, during my fellowship and since then, where it's like, I totally agree that after our residency, especially Mizzou, I mean, what a great residency. Mm-hmm. I think we came out really well trained. I mean, awesome. Like, flies under the radar probably still. I think we kind of ruined the secret, and I think people know it's a great residency, but it just came out feeling, I think both of us, like we could practice very well comprehensive ophthalmology. And like you said, we could have the experiences over time that make us, more comfortable on the refractive side, or maybe doing a little bit more on the cornea, ocular surface, whatever it is that we found attractive, we could do in our own practice over time. But you're exactly right that it's like you join a private practice fellowship or an academic fellowship, something, whatever it is, going into it, you're going to do a certain number of cases of a certain specialty with mentors that are going to kind of fast track everything for you, because their practices have been honed over years, and they have just a certain patient base, and they see a certain number of patients and do a certain number of surgeries that nobody could possibly do 1 year out of residency. So honestly, from their standpoint, from my mentor standpoint, it's like, it's gracious of them to offer that, to say, come into my clinic, come into my OR, and I'm going to train you even more than you had in residency. So I'm just always super grateful. I know you had an awesome mentor with Bill Wiley as well, but Jonathan Solomon, what a mentor. Just incredible, man. So to everybody out there that's listening, that's a medical student or resident thinking about or applying for fellowship, I'd give the advice that it really, really matters who your mentors are, more so than a name. So you could go somewhere where there's a great name and not have a great experience, and vice versa. You go somewhere no one's ever heard of, but with great mentors, and you'll come out feeling so much more confident in your clinical and surgical skills. And that's what it's all about, right? It's all about, just getting the best possible training you can. And luckily, I think in ophthalmology, we're kind of spoiled that almost every fellowship is really good. It's just finding, like you said, the personality that you get along with. You spend a year very closely with these 1, 2, or 3 mentors. Usually don't have that many mentors for that year. So you really need to get along well with them on a personal and professional level. So I think there's pros and cons to everything. We can get into kind of private practice fellowships versus academic fellowships. And our specialty is kind of cornea, as I call it, versus like refractive cornea and, refractive cataract and cornea fellowships. I think they're all necessary and they're all really good. It's just, what do you want to end up doing with your career? And you can always pivot too. Surgical skills definitely can transfer to different procedures that you could do that you didn't learn in fellowship. As one of our great mentors says, the stuff he's doing now, this is Dr. Hainsworth, stuff he's doing now, he didn't learn that in residency and fellowship, 95% of what he's doing now just wasn't around then. The one thing that was, though, he's on the cutting edge of, remember that? He was learning vitrectomy from Dr. Mockamer, who invented it at Duke Eye Center. Super cool to just be like cool. Connected directly to the invention of vitrectomy.
Yeah,
which is cool. Which is something you've never done. Fun fact: you've never done a vitrectomy, so keep it that way, man. Yeah.
Yeah, I appreciate that. I'm not even going to comment on the validity of that statement. We'll just leave it ambiguous.
You've only done them with Dr. Al-Keeb and Hainsworth with pars plana ports and everything.
Yeah, I've only done them on a scheduled retina rotation planned.
Yes.
Yeah, exactly. No,
beautiful.
I know you bring up actually a really fantastic point that I will touch on briefly is for any kind of resident. I know my mindset when I was a resident was, hey, I just want to ever avoid having to do an anterior vitrectomy. I don't want a PCR. I don't want any sort of issues. But I mean, it's going to happen. You do enough surgeries.
Everybody.
Yeah. Yep. It doesn't really matter how great a surgeon you are. I mean, the patient, the surgeon, the circumstances that, at some point you do enough and you're bound to have one come across your OR table. So yep. I think just being prepared for that is always a great thing. And Sam and I both had great mentors. So they taught us the importance of that and made sure we were prepared. So I think that's always something that you should be willing to face, even though you might not want to face it. Yeah.
I think we should do a whole episode on surgical complications. I think that would be really great. I mean, from a patient perspective as well, and from a resident and fellow level. I think people could get a lot from that because it's not about, like you said, it's not about not having complications. Anytime you operate enough, you're going to have some complication, some difficulty, whether that was existing beforehand, which is possible. There's trauma, there's things that happen to people's eyes where they're just complex from the start, or something unexpected happens. But like you said, just being prepared, and people can still have fantastic outcomes. I remember thinking as a resident, if you have a PCR or what we call break the bag, it's like the worst thing in the world, but it's something we really try hard to avoid. But if it happens, people can still have wonderful outcomes. You just have to manage it well and know what you're doing.
Exactly. Yeah. But even talking a little bit about how you touched on the private practice fellowships, I can talk a little bit about that because I do have direct experience with that. So just talking a little bit about private practice fellowships, since that's what I have the most experience with. I just completed a 1-year fellowship with Dr. Bill Wiley and Shamik Bafna at Cleveland Eye Clinic, or Clear Choice LASIK in Cleveland, Ohio. That ended in July 30th of 2024. So I'm just a few months out. Everything's fresh in my head, and I loved it. I had a fantastic experience. I would 100% do it again. And I think some of the distinctions that we need to note when we're talking about a private practice fellowship are, one, you're usually not around other fellows or residents anymore. You're in a private setting, although you can have affiliations with an academic center in which there might be residents rotating or medical students rotating. And you might have to give some lectures here and there to those learners. But the other thing is, I think, and Sam, maybe you can touch on this too on your experience, but for me, coming into a private practice fellowship, I think I was granted a certain level of autonomy that I would say may not always be seen in a more academic institution, where there's a little more hierarchy and structure and more of a chain of command to bounce things off of. Whereas in a private practice fellowship, yes, you have your mentors. They're always available for texting or calling, but really they kind of give you a lot of independence to manage things on your own. Because at this point, you've already completed a residency. You are an ophthalmologist completing your having completed your training, and this is an optional experience. So I think that's great because it really pushes you outside of the box and really tells you, I need to think like an attending. I need to be self-sufficient. I can't really just bounce this onto someone else's lap and say, okay, it's time for you to handle this. The buck kind of stops with you. So I think that's a great experience as well. And then another third thing I would say is just looking at surgical numbers and volume. I think when I did my interview process and I was looking at programs, I looked at your what you would call true traditional academic cornea programs, and then also these private practice refractive programs. And I kind of had an idea for what I wanted to practice after I was done with fellowship, and that was heavily more refractive than it was true cornea. And so that helped me look for the private practice fellowships that boasted these high numbers of refractive surgery, cataract surgery, premium cataract surgery. And I would say that I definitely got the experience I was looking for by completing this fellowship. So I think those are just three different nuances in the private side compared to the academic side. One being that kind of hierarchy is a little bit different. You don't really have other co-residents or co-fellows to manage with. And then the autonomy, and then moving on to the surgical numbers in that field that you're actually picking. True cornea program would definitely give you way more experience in managing conditions like fungal keratitis, and also doing surgeries like penetrating keratoplasty or DMEC or DSEC. Whereas I think these more private refractive programs are going to give you more volume of doing cornea-based refractive surgery like LASIK and SMILE, and also doing intraocular surgery like cataract or premium cataract and EVO ICL.
That's so well said. I think the only thing I'd add is, at least when I was in residency, I felt like there was, first there's a decision whether or not to do fellowship, and luckily we went to a program where they're very supportive either way. It's not like, oh, you have to do a fellowship. Some programs I felt like that my friends were at, it kind of felt like that. Like, oh, what fellowship are you going to do? Not like, are you going to do a fellowship or not? But the second thing I'd say is that there was a feeling that the fellowship, like private practice versus academic discussion that we're having, that was something where it felt like the academic centers, because all residencies are through academic institutions, right? So then when you go to fellowship, there's an option to continue kind of in that academic world that we've been in since medical school, or join a private practice fellowship like you did. And it felt like there was, it felt like it was inferior. Like people thought lesser of those fellowships. And I think hopefully that's gone by now, but if not, hopefully we can kind of eradicate that, because I think they have so much to add for people that want to go into private practice or even academics. I mean, they can go back into academics after that private practice fellowship and add so much. So I think that intermingling of ideas, if you went from a private practice fellowship to academic, would be a great thing, and vice versa. So anyway, I just thought, I don't know if you had the same impression, but it felt like a little bit of a gamble, and I don't think it needs to feel that way. If you find a mentor that's great and a fellowship that suits you well and that's what you want to do for your career, go for it. That's awesome. And just a quick aside, Sud's a year below me at Mizzou. So I was in fellowship when he was applying for fellowship. And when he told me he matched with Dr. Wiley and Dr. Bafna, I felt so proud. I was like, I'm so happy for you. Like, I know it's going to be an awesome year. You're going to get so much good experience. So I was thrilled, man. I felt like I matched again, and I was so happy.
Well, I know you were a fantastic mentor through that entire process. So I really want to thank you for that. And I'm very appreciative for all the wisdom and knowledge you imparted to me. I think, I don't know how many times I probably called you or texted you throughout the whole application cycle, but probably way too much.
But seriously, so happy for you. Like, what an amazing year.
Well, I appreciate all the kind words, and I'm very excited to be finally out here in the Bay Area and getting started here soon. So I think you like go through all this journey and you never really think you're going to reach the end, and then you're kind of at the end now where the training part's over and you're like, I'm ready to go. I'm finally here. So that's excellent. How's been the past 1 year for you? Because we did the same type of journey, but you've been out for a year, and I know you've done so many amazing things in this past year. So I just wanted to hear from you after 1 year, how you feel.
Thanks. Yeah, it's crazy to put it in perspective that it's been a year. It feels like it flew by, and it also feels like so much has happened in that year.
Mm-hmm.
It's been awesome. I mean, the fellowship and the residency training and med school, everything pays off in the end. So for people that are on the journey, like you said, there's this feeling that you're never going to reach the end. That's a very real feeling, and then you get to the end, and hopefully you take a good vacation and hang out and enjoy that time, and then get started. And it's just like, it's hard to believe that you're doing it. So yeah, it's been a year, and doing the full breadth of everything from full cornea penetrating keratoplasties, that's like full thickness grafts, to introducing DMEC to our practice, which is cool. Nobody had been doing that in our practice, and even in our surgery centers that I go to. So that's been awesome to introduce. Evo is something that also got to introduce, because that was something I felt very comfortable with after fellowship. We were lucky to come around when Evo, had been approved. It'd been approved for a couple of years at that point. But other, ophthalmologists had been practicing for 20 or 30 years, that had done previous ICLs, just hadn't seen this huge leap forward that Evo has provided for us. Between that and cataract surgery, PRK, LASIK, I mean, it's been awesome on the surgical front. It's awesome to have kind of a community and other eye doctors who also kind of trust in your expertise, and you trust in their expertise when you co-manage with them and share the patients with them. So it's been awesome. It's been a really cool journey. I mean, there's so many things that we learn in residency and fellowship, but we don't get to practice, or some things we don't even learn. We don't really do a lot of shared care model where we have other doctors that are co-managing our surgery patients. So it's just been super, super cool, and I'm just thankful, honestly, after a year, I'd say this like almost every week without fail, if not every day. We're just super lucky to get to do what we want to do. We love, at least I love, and I think you do too, operating and seeing patients and helping people improve vision. It's lucky. I have patients tell me that too. They're like, "You must be so happy doing what you do. You're so lucky." And I'm like, "Yeah, you're exactly right. If I wasn't paid for this, I would still do it. I love it."
Yeah, it's a truly amazing thing. And also, the other thing you didn't mention, which I thought was so cool, was you also did a mission or a medical trip abroad just recently, right? Not even 2 months ago, or
yeah, it was that's right, like the end of August. And we're actually going back in a couple weeks, about 3 weeks, going back as well. And it's incredible to be able to provide that care to patients internationally as well. Cataracts are such a preventable cause of blindness, a treatable cause of blindness. And the really cool work that's done there is twofold. Number one, the optometrists and the optometry students that we go with, they provide glasses and actually make custom glasses for patients that otherwise wouldn't be able to correct that easily correctable refractive error. So kids that would grow up and maybe be amblyopic, or go their whole lives without knowing what a clear vision is outside of right in front of their face, or if they're hyperopic, any clear vision. It's amazing that they can provide that service to people. And then the second thing is working with local eye doctors and local residents and fellows. So getting to pass on what we've learned surgically, our training, and pass that on so it's more self-sufficient, and that area can be better treated by their own local doctors. So hopefully you go enough times and train enough folks in that area, they become self-sufficient, and you can pass that on somewhere else. I mean, I think that's the goal for almost every surgical mission trip that we do in ophthalmology, is to spread our training. We're just lucky to be in the USA, born when we are, practice medicine the way that we do, and just, I think it's our responsibility to go out there and spread that the way that it's been spread to us.
Yeah, exactly. It's kind of the give a man a fish versus teach a man to fish. So I like that. It's a worthwhile mission. So I'm excited to hear what happens in a few weeks when you go back and you tell me about it. Talking about the fellowship experience as well. I mean, you and I had a great experience during residency where we had mentors like Dr. Hazeman who would sit with you watch your videos after surgery and really go through it in detail, like hit pause, highlight, aspects that you did well, but then areas that you could have done better. And I think that's so helpful when you're learning it to just basically break it down, because as you and I both know, when you're operating, your brain's going at 100 miles per hour. You're thinking about all this stuff, and you might be doing subtle things with your hand or your finger or the way you're holding the instrument that is suboptimal. So then to later play it back and break that down and learn from it is instrumental. But that same experience, I would say, I had during fellowship. And part of that, to your point about you could go to a great name place and have maybe not the best experience, or you could go to a place that's not as well known and have a wonderful experience due to your mentors. I think that ties in a lot, because if you have a mentor who's willing to spend the time with you and go over those videos and kind of recap the day and walk you through things that you could have done better, I think that's going to just make you a much better surgeon and clinician. And so those are things that I would point out to residents who are looking for fellowship programs, is trying to get an idea of how much mentorship are you really getting? Like what's the quality of that mentorship? And you can definitely ask people who have done the fellowship in prior years. You can look online. I'm sure you can get a wealth of information on there as well. But there's so many tiny little things like that that might not be well understood by just looking at a fellowship website. You really have to kind of dig a little bit deeper to get that information.
That's great advice. I think we both did that, right? I mean, we talked with our own network of people that we know and then reached out to previous fellows. All that is super important when you're applying. When you were talking about how lucky we were to have Dr. Hazeman and Davis and everybody who would go over surgical videos with us, Dr. Cardinal, they're all fantastic. Yeah. But as a resident, I don't want to say it's your responsibility, but it really is your responsibility to record every case and watch it back yourself, because that's game tape. We've talked about this before. You gotta just dissect that yourself, and then hopefully, if people are there, if other residents or fellows or hopefully attendings are there to watch those with you and critique it and give you feedback on how to improve. Hopefully they're there to do that for you. But if not, I'd say ask them. If you ask them, they'll do it. If somebody came to me right now and was like, I have, 10 surgeries and I want to watch these with you. I've edited them down to the points, where I think we could improve, or, they're unedited, whatever. I would be so thrilled to go over that with people. So just because people don't go out of their way to say, let's watch videos together, a personal story about how nerdy I am, I was like, let's make some cataract video nights, even after work hours. Let's bring some videos. Let's all hang out, have attendings come and talk about ways we can improve. And that helps the whole culture, just bonding, talking about these things, pushing each other surgically. I remember with you and with Andrew Plummer and other residents, not competitive in a bad way, but being competitive and we're pushing each other to be better. We want to be as efficient and as safe and as good as we possibly can be. And I think that's a great culture to have, just like in any professional sports team or locker room or whatever. You're just going to get better and better by working with people that are really, really devoted to their craft.
Definitely. And I mean, even when you're talking about things that you might have done better, let's say you had a complication or something like that, by you sharing that with someone else, I think it gives them a lot of like a comfortability to be able to share their own experiences, and then realize that everybody kind of goes through certain situations that were difficult or challenging, and then how do you learn from that so that it doesn't happen again? So having other people dissect those videos and talk about things that went wrong, even maybe it might not feel the best at the moment, I think it's fantastic in the long run.
Yeah, and I think it's all of our jobs to promote a very inclusive and very accepting culture in ophthalmology. I know a lot of surgical specialties can have the reputation of being cutthroat, and luckily ophthalmology doesn't in general. But still, like you said, it's kind of like burying your soul to be like, I was operating here and there was a complication and I don't want that to happen again. So let's go over the video and figure out how we can at least minimize that chance of that happening again. And as a as a department, as a residency in ophthalmology, you need to be supportive of one another. Nobody's trying to do the wrong thing. Everybody went into medicine, went to med school, went to residency, all with their heart in the right place. So just being supportive and trying to help each other out is definitely the move.
Yeah, I totally agree. There are things that we can kind of touch on that experience between private versus academic that came to my mind when we were talking about watching videos is also watching videos when you're doing like a new procedure or a new technique, because you're kind of starting from scratch there. And I would say, at least in my experience with the private practice fellowship realm, you do get exposed to a lot of new technology. You do get exposed to industry a lot, and so that was something I was looking for as well. How do I get these kind of industry connections that might help me in the future? How do I get my hands on some of the newer technology so I can play around with it? And I think that experience you might get a little bit more in a private setting. You can definitely get it in an academic setting, but I feel like, at least in my experience, the private settings are a little more amenable to that and kind of will adapt to that a little more rapidly. I don't know. What are your thoughts on that?
That's a great point. I didn't really think much about, but that's 100% true. I think of our residency, and we did have some industry connections, but a little bit for sure, but much more so that I experienced in fellowship. And now that I've had that experience in the past year in private practice, I've had even more. It's just we're super lucky, not just what we do, but who we do it with. Our community of eye doctors and our industry are both amazing. Every company that I've come across that we work with, their representatives, their CEOs, everybody on every part of it's incredible, super supportive. You can tell that their mission is the same as ours. It's just working kind of hand in hand with them. So when it comes to like certain, new technologies, having that industry connection is super important, because they'll be the ones that will introduce that to the OR, introduce that to you and to your patients. That's an awesome point.
Yeah, I feel like it's helped me, especially as I'm now joining a private practice center now here in California. Having those connections are hopefully going to help me help my patients. And I don't think I would have had the same level of experience if I didn't go through this route, or this kind of private practice route. So I'm very grateful to my mentors for that and for that experience.
Well, I think just to kind of recap what we're talking about, there's all sorts of different fellowships. So number one, deciding whether or not to do a fellowship. And that doesn't mean that it's any amount less to go into comprehensive ophthalmology and not do a fellowship. You and I were both lucky enough that we could afford to do that. I think that's one topic that we could hit, which is you come out of med school and residency and you're just full of debt. You're just riddled with debt. And if you have to start immediately providing for your family, paying off loans, doing all these things, it might not even be a viable financial option for you, which is sad, but true for a good number of people. I think fellowships are getting better about having a good kind of cost of living salary, but it's not the salary you could make if you were going into ophthalmology general practice immediately. So you kind of have to weigh that pro and con on the financial side as well. Now, I think if you can make it happen and you want to do a fellowship, that 1 year less of earning for your whole career, it's not going to be substantial. The things that you can do as a result of doing fellowship, I think are very worth it, or at least feel more comfortable and be more equipped for, at least quicker after fellowship than you would be out of just straight residency. So I don't know your thoughts on that, but I know there's some people that are like, you know what, I have too much debt. I can't do another year of training. I just need to start making money and paying back loans and providing for my family. So,
yeah, I think that's a very valid point, and that'll be a very personal decision for each person. And you're right. I think you and I were just fortunate where we were able to make that decision and say it's not going to be a gigantic financial burden, and our family will be able to be okay with it. But it's something that everyone needs to think about. It's one of those real nitty-gritty realities of medicine that maybe isn't talked about as much. High amount of debt, long amount of training. Do you really want to extend that any further? That type of thing. Yeah.
Yep. One podcast I listen to all the time, White Coat Investor, huge fan. Really good for financial advice and financial just knowledge for especially med students and residents. We had one of our scribes that started med school at St. Louis University at SLU in August, and that was the book I gave him. I was like, this is the book you need, White Coat Investor. Take this book, listen to the podcast. You were saying that we were lucky to be in a position to do fellowship and take that year of additional training. It's just because I love the 2 R's. I love ramen and roommates. I just love, eating as cheap as possible and having roommates for another year.
Yeah, exactly. I mean, you've been doing it for so many years so far. Why not just tack on another one? Yeah.
Yep, it's true. Yeah. Well, we're kind of wrapping up here. Last couple minutes, we can do a little bit of news, like maybe just a little bit of ophthalmology news. And then we could even do a video if we're up for it, or no video, whatever. But
let's do it.
All right, the news that I heard, I think it was Thursday or Friday.
Breaking news.
Breaking news. Do we have we'll put a little segment in here.
We need like a little segment,
audio, like a news ticker. Yeah.
Yeah.
The B&L, Bausch & Lomb, Envy, their full range of vision lens came out, and I'm super excited about it. Just excited by any new technology. You know me, just like the newest thing. We're lucky. We're kind of spoiled, though, that we have a lot of good lenses in our armamentarium. So as excited as I am by the announcement, I'm also like, am I going to adopt it? Am I not? It's going to be something that we try out, and the data looks really good. The data looks solid. That defocus curve was impressive.
Yeah.
I like the patient reported outcomes as well. But there's no better patient reported outcome than doing hundreds of one type of lens and having hundreds of happy patients yourself. So going away from what we're used to doing and the lenses that we like, it's tough, and we just do it if it's the right thing. If it's the right thing for people.
Yeah. I think it's always great to have more options. So I am excited about this, and I always like trying out new technology. So I will be following it pretty closely. But like you said, I think nothing really replaces getting it into your hands and seeing how it works for you. And I think I read something online that was saying, despite what manufacturers will post about their results, we look at that obviously, and we take that into a lot of consideration. But a lot of ophthalmologists actually like to hear from their peers about their experiences using a certain lens or whatever instrument technology, and we kind of trust them to tell us their experiences, and that weighs in heavily on whether we're going to adopt using a new technology. So I don't know how you are with brand new technology. I'll only talk about myself. I'm interested. I definitely want to try it. I'm very excited about it. But at the same time, I'll probably give you a phone call, or someone else a phone call, and be like, how have you liked it? How's it been in your patients? And from that, kind of see how I'm going to implement it.
Yeah, it must be our Virginia upbringing, because I'm the exact same way. I think I'll probably give you a call and be like, have you used this? Are you using it currently? Do you want to use it? Get your input. And excited. We'll have decades of bouncing ideas off each other like that. It'll be cool.
I love it. We'll be the Spider-Man meme gif where we're just both pointing at each other, but standing right across from each other.
We'll see. And then we'll have some third. We're going to go 5x speed. I'll slow it down for certain parts, but this is a cataract surgery. And we are doing, I don't operate this fast for anybody watching. We're just doing this for the sake of time.
For people who aren't watching, the capsulorhexis, which I just saw, is like a perfect circular, beautiful capsulorhexis. So
thank you. That one I did an extra little regrasp at the end. Yeah, if you really grab the last little strand and make it anyway. Yeah, thanks for that's. You're just boosting up my ego. It's very kind.
No, very sweet. Beautiful.
But right now we're doing just a classic divide and conquer for people listening. Just commentating on this surgery, which, feel free to jump in, Dr. Koushik, because I'm the one doing the surgery. You can critique it for sure, but just a divide and conquer with a Cybele. Nucleus is fully out now. We're going to INA. Love this disposable INA 45-degree tip. Silicone, just super, super gentle on the bag. Yeah, just kind of a regular case here, just polishing the bag, because we're planning on a light adjustable lens. So the reason we're watching this video is light adjustable lens, and I'll slow it down here just for a second for people watching. Right here, we're going to enlarge the wound slightly. So I operate through a 2-4. and the LAL goes through. Don't quote me. I want to say 275. Is that right, Dr. Koushik?
Yeah, I think that's right. I'm gonna double
Okay.
check right now.
I think it's a 275. I mean, you can stretch it to what you want, but so here we have the capsular bag fully inflated with visco. You definitely want a nicely inflated capsular bag. And we are going to inject the LAL, making sure it's loaded perfectly. And it's a silicone optic. So it comes out as a 3-piece lens. You want to rotate that first haptic into the bag and then rotate as you're inserting. And it kind of right here just kind of pops out. It's gentle. People give it a bad rap, and you can use the plunger to inject that trailing haptic, or what I do is use either the INA or a second instrument to just dial that into the bag. I think here I just use the INA. So you just inflate. You can do it either with the infusion on or just with the viscoelastic, and just like that, it's in the bag. And I'd love to hear your feedback on your first few cases when you were doing LALs, because it is a little bit different injection. But my takeaway, my general takeaway is the reps and the company are fantastic with going over exactly how to load and inject it. So take their advice, go through that training, and you'll be confident. You'll be fine. Yeah, there's nothing to worry about. Don't let that stop you from doing LAL. Light adjustable lens, beautiful lens.
Yeah, it is a great lens. And for those who weren't able to watch the video and just listening, Dr. Barry did an awesome job of dunking using the optic haptic junction at that kind of point with the IA probe, which I think is always a great way to kind of wheel, turn it in there and dial it in there and make sure that trailing haptic gets into the bag. So right here, he's showing it again. Just, it's beautiful because it's one smooth motion and you're not really kind of messing around too much with the lens. So I always like doing it that way too. And then just talking a little bit about the LAL too, and working with your reps. I think we've talked about this before, get in the wet lab, just feel really familiar with the lens before you have the patient ever, get on the OR table, because it is a different kind of loading experience, and you want to feel very comfortable with that if you haven't done LALs before, or kind of 3-piece lens type surgeries before. So as long as you're familiar with that, it's going to just make it easier when it comes to that part of the surgery. And then in terms of the rest of the case beforehand, I mean, I think the best part is just standard cataract surgery. You're doing your normal stuff. And then the difference there is more when you're implanting the IOL.
Yep. Yeah. I totally agree. And quick pearls about the light adjustable lens itself. I mean, number one, for people that we haven't lost yet, listeners we haven't lost yet, it's the only adjustable lens post-operatively. So that's super, super cool. The optic material, the silicone, is awesome. I mean, the number of patients that are 2015, it's impressive. I mean, it's a really, really good optic. Yeah. And the third thing I'd say is the 3-piece lens, very springy. I feel like I just love the feel of it when it's in the capsular bag. I don't know about you, but I feel like I can definitely tell the difference. Those haptics really open up, and it's just spring-loaded, and it's just in there nicely in the bag. Is that your experience as well? It feels different than a single piece, which is what we're used to for a lot of surgeries. But it's just, it's an awesome, all-around awesome lens.
Yeah, I totally agree. Definitely, it feels different than a single piece. And I think if you're a resident who's primarily done a lot of single-piece lenses, then switching to this gets a little bit of a change. But you pick it up very quickly. And that's what I was saying more with the wet lab, just get that experience beforehand. But it is a great lens. And I think that was a great video. You said we do have another video we're going to share, and that one sounds like it's going to be really interesting. I mean, not that this wasn't. This was interesting as well.
This is a snooze fest. This is boring. I know. Yeah, this is a patient that was referred to me for a failed DSEC. I had pseudophakic bullous keratopathy. You can tell from this video. For the people watching, you can tell it's a clouded cornea. Try to see those iris details. Yeah. I'm not out of focus. It's just the just the cornea is cloudy, and you can see. Can you see the DSEC graft?
Yeah.
So it's nicely attached. The person did a great job. It was just a primary failure. You can't really see, but the pupil's a little bit irregular here. There was actually some vitreous going to the paracentesis as well. So kind of had to deal with that first. I'm going to skip around in this video a little bit.
How long after the DSEC, the primary DSEC, are you doing this surgery?
Yeah, so this surgery is about 3 months afterwards. They were referred to me after about a month. And I told them it's best to just wait because it can clear. It's possible. It was that period that we were just trying to allow it to heal up, from a month post-op when typically we'd see it already clear to 3 months when we can say, okay, this is not going to clear. Let's go ahead and do a repeat surgery here. So again, this is the DSEK graft that we're going to take out first. I like to put in this AC maintainer, a Lewicki AC maintainer in the nasal paracentesis there. And I love, this is something I learned from Jack Parker, stripping under air. Awesome. You can see Descemet's membrane so much better under air, and you don't even have to use viscoelastic in these cases as well. So you just have your assistant just pushing on the air, and you can see how that DSEK graft just wants to come out. You don't have to strip Descemet's like you would for a primary graft. I do strip a little bit more. I'll skip ahead through that just to make sure we have all the little bits of Descemet's out of there. This is stripping just a little bit more because I do a large diameter graft as well, way out to the periphery. Did a inferior PI as well. I'm going to skip ahead some more. Taking out the air. There's that little bit of that strand of vitreous. Just making sure we can get that pupil to be round, making sure there's nothing else prolapsed. And then once we're done with that, just forming the AC with BSS again. And I don't want to skip the fun part, which is graft insertion. And feel free to stop me if you want to hear more about boring cornea stuff, Dr. Koushik.
No, this is fascinating. I want to see.
But the DMEC graft is just, the endothelium and Descemet's membrane preloaded into this tube. And you can go through a 2-2, 2-4 incision and insert it just like you would for like an IOL, basically.
I want to see the tapping technique here, see how well your drumming
I'm skipping forward a little bit, but the Dirasomer techniques here, there's different techniques that we use, but this is sorry for the people watching on YouTube, this is a bouquet formation. The glare off the surface of the eye and the cannulas and stuff makes the exposure come and go. So it's not that the light is actually getting dimmer and brighter, but it's just the exposure for the camera, the surgical camera. But yeah, we just unfold this. Unlike a DSEK, a DMEC, that tissue is so paper thin. I mean, not even paper, so cellophane thin that we can't really touch it directly. There's nothing wrong per se with touching the stromal side, but it just doesn't behave the way that you want it to.
For our listeners, can you tell kind of some averages, thicknesses between DMEC and DSEK? Because I know DMEC is considerably thinner.
Yeah. So, here we go. So it's good unfurled here. I'll pause for a second and just answer your question. So DSEK has come a long way. It used to be quite thick. So the cornea, for reference, is about at the apex about 500 microns thick. That's about 0.5 millimeter. And so DSEK originally was in the 150 micron range. So that's like a third to maybe a fourth of the corneal thickness. So that was stroma in addition to the endothelium. So that's why when you put it in there, it's like a disc. You just put it in there. It doesn't even unfold. It's just the way it is. And then you put a bubble in and it's attached. But as we can get thinner and thinner grafts, we can get better potential visual acuity. That's not to say that DMEC is better than DSEK, but in some ways it shows some superiority. But the ultra thin DSEKs that we can do now are so thin that you can get to almost 75 or so microns. Very thin, ultra thin or nano thin DSEKs. But for reference, DMECs are really just the endothelium and the Descemet's membrane. So we're talking about like a few microns, just very, very thin tissue. Similar in kind of dimensions to the capsule, right? That's kind of what we're talking about. So here the endothelium is stained with trypan so we can visualize it. And it's also stained with these peripheral markings, these 1 and 2 stamps. Actually, here it was upside down. So that technique of injecting BSS, I don't know if you saw that, Dr. Koushik, but
yeah,
you unfurl it and you see the 1 and 2 peripheral markings, and it's counterclockwise, like 2 here, 1 here. So what we would need to do is inject this stream of BSS to flip it over. So that flipped it over, unfurled, looks nice. We just need to center it up. A couple more taps on the cornea. And then we inject, and what you can put in there is either air or 20% SF6. And this patient, we did 20% SF6, and we're about to inject that gas bubble. But as you can see, I mean, I fast forwarded a little bit, but the surgery itself does not take that long. It's an amazing, amazing gift that people donate their corneas, and it's an amazing gift that we have the technology to do such an incredibly thin and delicate graft. In the past, what we'd have to do is a full penetrating keratoplasty, a PKP, for these patients. And I don't know about you, but I don't love opening the eye to the sky unless we absolutely have to. So the amazing, part of this surgery is it remains completely closed. I actually have transitioned to sutureless for this as well. So the AC is just maintained by the air bubble or the gas bubble. We have the 1 and 2 orientation, and this patient's about 2 weeks out at this point, 2 to 3 weeks out in that range, and doing super well, clearing up. It looks great. So happy to report that he's doing really well. Sorry to bore you with cornea, but
no, it was a smooth technique, and I'm glad I got to watch it, dude.
I think the YouTube channel, social media channels, everybody can follow, we're on Spotify, Apple Podcasts, YouTube. Mm-hmm. It really helps to even leave a review. I've never done that before, but I really should for the podcast I listen to. So if you can do it for us, it would be super helpful. It actually helps us tremendously. Yeah. Well, great episode, man. That was awesome. Great to catch up. Thanks for all the listeners that made it this long. Another episode of Now I Know. We're going to start, people ask me, people are listening. People are asking when we're going to have some guests and they want to come on. So we'll have to get a list of people and start doing some interviews too.
We got to do it. Yeah. Great episode. Thanks so much, Sam.